Good afternoon and welcome to the Maine Health Management Coalition's webcast on the Maine opioid crisis, tools to scrub and eradicate our epidemic. My name is Marie Stuckey. I'm the Member Relations Specialist here at the Coalition, and I thank you for joining us today. But I want to reach out with a special thank you to our presenters for their time and participation in sharing their expertise, and I will introduce them shortly. I'd like to begin just by giving you a brief overview about the Coalition for our listeners who are not currently members, and some information on some upcoming events. I'd also like to draw your attention to the fact that in your GoToWebinar control panel, you'll see two handouts that our presenters have provided today that you can use for your resources and information. If you have any questions during the presentation, please type them in the chat box in the control panel, and we will compile them and have a question and answer period at the end of the broadcast so that you can, I will relay those questions to our presenters for you on your behalf. The slides and the webcast itself is being recorded, and they will both be available on our member website, and I will email people so that they have a link to get to that spot and reference it at a later date. So let me just start. Oh, and I'd also like to ask you at the end of the webcast to complete a survey, if you would be so kind to let us get some feedback on how you felt this went. So I am going to just tell you a little bit about the Coalition. We are a multi-stakeholder nonprofit organization. We're purchaser-led, and we have our stakeholders in consumer advocacy groups, purchasers or employers or plan sponsors, health plans, brokers, benefit consultants, providers, and affiliate groups all convene together to collaboratively improve health and maximize the value of healthcare services in the state for them as members and all the citizens of the state. And right now we have over 80 members. We accomplish our mission through 5 key initiatives, the foundation of which is our data department, where we have all the state's health benefit claims. And with that, we can do benchmarking to compare benefit plans, see where spend is coming from, and help providers as well evaluate their quality. We also work on transparency and public reporting through our website, our consumer website, Get Better Maine. And here you will find quality and cost information on the care provided in the state. We also achieve our mission through engaging our members and their employees by giving them resources of information on everything from diabetes care, cancer care, and just personal responsibility for health and well-being. We have people that work on benefit design. A lot of the large insurance carriers in the state work with us on simplifying insurance design, and that is a component of what we do as well. And finally, we work on payment reform, where we explore alternative payment arrangements with providers and hospital systems to get costs down. So we are very proud that we've been able to achieve some savings in the state. We rank high according to the Leapfrog group in hospital safety, and we attribute a lot of that to the quality measures that we publicly report. But some of the other benefits of membership include the ability to network with Maine health and business leaders and get connections that way, to identify best practices in health plan design, have access to our outstanding data analytics team, to train leadership and staff through educational events, and be guided to high-quality, reasonably priced healthcare services. Some of our members are also happy to have themselves branded as organizations that are working to improve the value of health in the state by being a member. A lot of members participate in our work groups. They have access to webinars such as these as a complimentary benefit of membership, and vote in influential coalition elections. They also have discounted fees on services and conferences. So some of the ways that we get members involved is through our newsletters, our webcasts, provider and employer roundtables, work groups, and some of our members have taken advantage of some member-only employee engagement pilot programs as well. Also, we have an annual symposium that was just held in November, and that is a very large event. It was very well attended this year, and it's a great opportunity to network and learn. I want to let you know that we have registration open for our next webinar, which is taking place on February 10th. It's Building and Addressing the Full Life Spectrum with a Culture of Health. We're very pleased to have Dr. Brent Pilecki join us for that. He's from the Goodyear Tire and Rubber Company, and he'll be discussing ways that his organization has implemented a program about end-of-life concerns. In March, we have a focus on diabetes, both for employers and for providers, where there'll be resources for both to help with that issue. This is just a slide showing some of our current members, and we thank them very much for their initiatives and support in improving the value of healthcare in the state. And with that, I'm going to now present our first speaker, Dr. Leah Bauer. She is with Midcoast Hospital. She's a psychiatrist and the medical director of the Addiction Resource Center and holds a faculty appointment at the Tufts University School of Medicine. She graduated from the University of Cincinnati College of Medicine and went on to residency at the Massachusetts General Hospital and McLean Hospital Adult Psychiatry Program, where she served as administrative chief resident. She has a strong interest in medication-assisted treatment of substance use disorders and addiction as it relates to trauma and women-specific issues. She looks forward to working to improve the interface of addiction treatment and primary care in her future work. Dr. Bauer will be joined by her patient, Deanna, who is kindly also contributing to this broadcast with some personal information about her experience. After Dr. Bauer, we'll hear from Terry Leisure. She co-coordinates the Employee Assistance Program for Midcoast Parkview Health Services and oversees the Central Intake Department and Outpatient Services at the Addiction Resource Center. She provides initial assessments for employees and members of the community to determine medical necessity, risk, strengths, medical and psychiatric need that result in plans of care for individuals seeking help. As part of this work, she works with stakeholders such as HR and wellness departments, supervisors of employees, and other providers and their family members. And with that, we will turn the controls over to our presenters, and thank you so much. That will be just signing on in 1 second here.
Okay, I hope everyone can hear me. I trust I'll figure that out soon. If not, thank you. I'm Dr. Leah Bauer. I really appreciate the opportunity to speak to everybody today. Thanks to Marie and to the Maine Health Management Coalition for inviting us. I am sitting next to Deanna, who is a patient of ours here at the Addiction Resource Center, who has so courageously and generously offered to come and share her story with you all today to help highlight some of the points I'm hoping to make. So without further ado, we will be talking a little bit about the opioid problem across the U.S. as well as in Maine, and then the majority of our time will be a conversation between Deanna and I, and then I'll go through some tools that can be used for prevention, identification, and treatment of opioid use disorders that Deanna will be highlighting in her story, and we'll close with some resources that are also included in the handout attached to the presentation here. So it's tough to open a newspaper or turn on the evening news these days without hearing something about the opioid crisis, which has really reached epidemic proportions across the country. And in fact, in 2014, 10.3 million Americans reported misusing their prescription opioids. This is over twice the amount that were reported in the 90s. Aren't people who are outright addicted necessarily to their opioids, but maybe taking them, overusing them, using them recreationally, using them other than for their intended intent for treating pain. That's a huge number that's roughly equivalent to the population of Maine, Vermont, New Hampshire, and Massachusetts all combined. Out of that number, almost 2 million of them have a diagnosable opioid use disorder, which is the new DSM, the Diagnostic and Statistical Manual terminology for essentially someone with an opioid addiction. It's replaced the old terminology of abuse and dependence. And an additional 517,000 have a heroin addiction. And we have seen subsequent increases in addiction treatment programs, which have quadrupled in the past decade, far outpacing the supply that these programs are able to provide. Here's a nice pictorial that was from a recent article in the New York Times that shows the correlative increase in opioid overdose deaths over the past 12 years. You can see it just lighting up like a forest fire across the country, largely stemming from the overuse of opioids and the overprescription of them. And these deaths, you think of heroin as being a drug that would be, less clean, less predictable, more likely to result in deaths from overdose, and that is certainly, heroin overdoses are a huge and growing problem, but this graph illustrates that actually deaths from prescription opioids are more of a problem, are far more common than deaths from heroin overdoses across the nation, and have increased from 1.5 per 100,000 people to 5.9 per 100,000 people between 2000 and 2014. You can see that these curves are starting to near one another, with heroin overdose deaths really increasing over the past 5 years or so, which kind of makes sense as many that are addicted end up turning to heroin as a more readily available and cost-effective alternative to buying prescription opioids illicitly. So where are these opioids coming from? This is from a very recent article in the journal of, in JAMA, the American Medical Association's Journal of Internal Medicine, showing that Medicare claims for prescription opioids, and the vast majority of these are coming from the primary care world, from family practice and internal medicine. Really, I think those two numbers combined would exceed the rest of the specialties on this list. I found this particularly interesting, given that opioids you think of as being particularly indicated for people with cancer-related pain, things of that nature. Hematology, oncology is about 15 specialties down. General surgery is 12 or 15 specialties down, where you see them dealing with a lot of the more acute pain that might be indicated for opioids. So you can this gives you a flavor for where those opioids are coming from. And then in Maine specifically, Maine has very high opioid use rates, and in fact, if you add up all of the pills that were prescribed in 2013, it would be enough for each individual in the state of Maine to have 60 of them. There are also is a high rate of drug overdose deaths in Maine. In 2014, there were 208 deaths. The 2015 numbers are not out yet, but they were on track to exceed the 2014 rates. Meanwhile, 131 people died from motor vehicle-related deaths, just to put that number into perspective. In 2014, most of the drug overdose deaths involved some sort of pharmaceutical, often various combinations of illicit pharmaceutical and street drugs. And also there has been an alarming rise in the rate of drug-affected babies in Maine, and now approximately 10% of live births are born drug affected, which is pretty astounding to me. So there's a little bit of background about the state of the opioid crisis, and now I'd like to turn to Deanna and and Deanna, to just say welcome to you, and thank you again so much for being here. I think that it takes a whole lot of courage to share your story, but the impact that it can have is really enormous. So thank you so much.
Thank you.
I asked Deanna to come in part because she's a very articulate and courageous person, and also because she came to be addicted to opioids after initially being prescribed them by physicians, which is a common story that I hear in my practice. And I thought that that would be of interest to that others could learn from it. So Deanna, could you just tell us a little bit about yourself to get started? Like, how old are you? What's going on for you these days with your family? Things
Sure.
like that.
I am 35 years old, and I recently have become a single mom of 2 children, ages 12 and 6. I had a career of 11 years, a pharmacy technician.
Okay, great. How long has it been since you've been working now then?
I have not been employed since 2009.
Okay, all right. And so why don't you fill us in a little bit about your past, because in getting to know you, I've come to see that you have a lot of kind of a risk factors that are associated with developing an opioid use disorder. So could you touch on like your family history of addiction?
Yes, I grew up with an alcoholic mother and an alcoholic father. There is 9 of us siblings, and unfortunately, each one of us have a addiction of some sort, which seems to be that it's genetic in our family, most definitely.
Okay, yeah. So it seems like the roots were certainly you're running deep there. How about your own struggles in the past? Have you had struggles with like anxiety and depression in the past before you developed trouble with opioids?
Yes, that's another thing that seems to be genetic as well. We have my mother was bipolar and manic. I was diagnosed with post-traumatic stress and anxiety and depression. Was actually awarded disability benefits because of my psychiatric disabilities. And many of my siblings suffer with anxiety and depression as well.
I don't want to go into too much detail, but could you tell us the nature of your post-traumatic stress? What kinds of traumas have you been through?
It was a traumatic childhood with the alcoholic parents, lots of fights and domestic violence. And then I, in my adult years, was in a violent relationship for 8 years.
Okay. All right. And how about back in when you were younger, were you involved in drugs and alcohol from as a teenager, for example?
I never had any interest in drugs and alcohol when I was younger. I remember times of crying and being upset watching my parents drink and use drugs, and it seemed pretty revolting to me back then. It was a long time before I ever experienced with it.
When was the first time you ever used a drug or took a drink?
I believe I started smoking pot probably my senior year of high school. And I believe I had my first drink when I was shortly after that.
Okay. Did you then start using marijuana regularly?
Absolutely.
Okay. Was it a daily thing for you?
It was.
Through your late teen years and things like that?
Late teens until I was 24 when I became pregnant with my daughter. And thank goodness that was the last time I experienced with marijuana.
You really used that opportunity to do what was best for your daughter and stop smoking. Okay, great. Was alcohol more of an issue for you too, or was it mostly marijuana back then?
I think alcohol was more of an issue. I drank alcoholically for sure. I would binge. I could drink way more than anybody, than a normal person would have a couple drinks. I would get that little voice in my head that said that I was becoming my parents, and it would petrify me.
Mm-hmm. Did you have any experiences with opioids back then?
I did not.
Okay.
I definitely had my fair share of filling prescriptions and working at a pharmacy in a small town. And even back in the early 2000s, I would see people that I went to high school with, just their lives being ruined by these prescriptions that I was ringing up for them.
Mm-hmm.
So I always knew that it was something very dangerous.
Mm-hmm. Did you see it around, though, or was that just something you weren't really in the same circles as people that were into that?
No, my circle wasn't into that.
Gotcha.
Mm-hmm.
Okay. So at 24, then you got pregnant
Mm-hmm.
with your daughter, and you stopped smoking pot and you stopped drinking too.
Yes.
And then what happened? When did you first ever use an opioid?
I was 29 and had my C-section with my son.
Okay. And what was that like? What do you remember about that? Did you take it in the hospital for the first time?
I'd taken it in the hospital for the first time.
Mm-hmm.
I remember asking for the smallest dose possible. I remember saying that I'm a mom and I need to be coherent and I need to be available for my children. But I remember the nurses and the doctors telling me that I would be no good to my children if I was in pain.
Okay, gotcha. And then how did that affect you the first time you took an opioid? Do you remember?
I remember falling asleep and not feeling in control, and it was pretty scary.
Mm-hmm. Then were you discharged from the hospital with a prescription then?
Yes.
And did you end up taking those, or what happened with those?
I did. I took them slowly. I would always take a half one.
Mm-hmm.
I would justify it by taking half at a time.
Mm-hmm.
Then I ended up with an infection in my C-section scar and was prescribed more.
Okay. And what happened then?
It was a while before I had been before I had another opiate, but I always had that little sensation voice in my head saying, "Oh, I remember how good that felt."
Okay, so you did experience some euphoria or some pleasurable feelings from taking the pills.
Yes, by the end of having 2 full prescriptions,
Mm-hmm.
I think my body adjusted pretty quickly.
Okay. What do you remember about that feeling? Like, what did you like about taking opioids back then?
That people, my close friends and family, would describe that I had no emotions. I believe that that's probably what I enjoyed the most, is that everything was numb around me, and I didn't have to experience any fears or anxiety.
Some of the more painful memories from the past. And,
Absolutely.
Other more challenging, anxiety-provoking situations in the present they seemed a lot more manageable.
Absolutely.
When you were using these. Okay. Mm-hmm. And then on top of that, was there more of a feeling of euphoria, too, for you?
In the beginning.
Mm-hmm.
In the beginning, absolutely. And that, I think, was something that I continued to try to chase and never quite got.
Okay. So then you had those first couple prescriptions, from the C-section and the complications of it, and then what happened? Did you get more shortly after that? Or?
Well, then at the age of 30, my body decided that I would have kidney stones. Urology was quite impressed with how large my kidney stones were, and that's when I was prescribed opiates on a regular basis for a 16 millimeter kidney stone that I had to eventually have surgery for.
Okay. Wow. Okay, so how long were you prescribed for that episode of kind of a care for your kidney stones, would you say?
From 2009 until 2014.
So that was really a chronic condition for you, and kidney stones are incredibly painful, I understand.
Absolutely.
I've never had to experience that for myself, thankfully, but...
Rather give birth.
Okay. All right, so did something shift during that time when you kind of crossed the threshold and you knew you were kind of headed for trouble, or did that come later?
That came kind of later, probably 2-3 years down. It was a weekend period where it ran out. of my prescription and my primary care doctor wasn't available, no big deal, I'll wait till Monday. And that was my first experience with withdrawals.
Okay.
And that's when I knew, like, how dependent my body was on these pills that I took every day.
Gotcha. Did you know about withdrawal before then, about that phenomenon? Or?
I had heard about withdrawals, but didn't realize how intense they actually were.
What was that? What is that like for you?
It was terrifying. It's hard to function and be a parent when you're shaking and creepy crawly and sick to your stomach and trying to explain to my children that I have the flu. Is how I would put it.
So it was really an incapacitating experience.
Debilitating.
Debilitating
Absolutely.
for you. Yeah, okay. And so that was a few years in that happened. So then what did you do? And did you end up taking other people's pills or something to avoid that? Or ride it through the weekend? Or?
I rode it through the weekend, and I remember going to my primary care doctor and telling him what happened and asking that maybe it was time to start weaning me off from these prescriptions.
Okay.
And he agreed to do a very slow wean process.
Okay. How did that go?
Unfortunately, I did not follow his orders and continued to take what I was prescribed, and more often than not, more than what I was prescribed, which I did not follow the weaning process.
What made it hard to follow it, do you think?
It was the withdrawals and the pain.
Do you remember how fast the wean was?
It was over a year.
Over a year, so it was very slow.
Very slow.
But even with that slow wean, the withdrawals were really still continued to be debilitating, and your pain became aggravated from that.
Yes.
Okay.
I was prescribed a high amount. So
Okay.
it was hard to come down from.
Okay, gotcha. What were you prescribed at your max?
15 milligrams every 2 hours.
Of oxycodone?
Of oxycodone.
Okay. Okay. All right. So then you were having a hard time kind of adhering to the weaning schedule, and then what happened? What started happening that maybe your doctors didn't know about?
That I would try to get out of urine tests.
How would you try to do that?
I would have other people urine for me. I would freeze it. I would bring it in with me. Or I would dilute it in the bathroom. Or I would drop it and then would have to come back. I would try to avoid urine tests at all costs.
But your doctors are doing them regularly, it sounds like.
No, it was pretty random. But I had that fear of never knowing when.
Okay, so you bring it in.
Always
You're prepared. Okay. Got you. Okay. What else?
It's probably about that time that I started taking benzos as well. Xanax, Valium, to intensify and or replace if I didn't have enough of the opioid to get me through the day.
Okay, so it would intensify the effect of it and help medicate the withdrawal symptoms if you didn't have it?
Absolutely.
Okay, so is that one of the things you were trying to kind of cover up in your urine? Or?
Yes.
Okay, okay, gotcha. Or anything else that was happening that your doctors didn't know about?
My primary care doctor, I'm sure, did not know that I was, at that point, buying prescription pills off the street as well.
Okay, gotcha. And were you always taking these just orally, or did you start snorting them or injecting them?
I always took them orally. I think I was scared that if I did anything other than that, then I would be an addict.
I see. So it was a way to kind of rationalize to yourself that your problem wasn't as bad as some other people.
I was justifying it.
Okay, gotcha. So what happened then to lead you to kind of come in for treatment? When did that scale tip and you were like, I need help?
When my prescription completely ran out, I had already tried with several doctors in the area as far as Portland and Lewiston. I had ended up having surgeries and unnecessary dental work done just to have a couple days worth of prescription meds. It was definitely taking a toll on my family and my loved ones. I had trespassing papers put against me from my parents. I wasn't allowed in their home anymore from stealing for money. And my partner of 6 years had a bag packed and was going to leave. And I have that overwhelming everyone leaves me feeling. So I made the phone call to ARC firstly to please him and to try to get him to stay. But once I got the taste of recovery, it definitely became about me.
Okay. What helped you fully embrace your recovery?
When I first came into ARC, I was not looking for Suboxone. I didn't want to replace one thing for another. Sitting in the IOP classes in the morning.
The intensive outpatient program, just
right.
Go ahead, just for those who might not know that.
It was very hard to concentrate on recovery, anything, when you're in full-blown withdrawals. The Suboxone most definitely helped me with my recovery.
Okay, so then after you weren't really able to get much out of the program, sitting there in withdrawal, then you made the decision with the doctors here to start on Suboxone. And
yes.
And that's been a lot better for you.
Absolutely.
What's your experience with Suboxone been like?
I can't imagine where I'd be without it. I just celebrated a year opiate-free.
Congratulations.
Thank you. At first, it was kind of triggering in the beginning. I would clock watch about when to take it, but I had to remind myself that I had to get used to it and that it would get easier, and it did. Eventually, it got easier. It's just part of my daily routine. There's no euphoric, no crazy side effects. It just gets me through my day.
It's really helping you get your life back. Huh?
Absolutely.
Okay, great. And what about other parts of your treatment? Can you just speak a little bit about what else in your recovery has been helpful? I know you're really involved in the 12-step community and also in some other treatment groups here.
I am. There is a aftercare group that I look forward to coming to every week. 12 steps is something I'm very passionate about. I enjoy helping other people. It's important to my recovery to help others.
Okay, great. And by doing this, you're helping others in ways that we probably can't even quantify. So.
Absolutely.
But in closing, Deanna, is there anything else you wanted to add about, what you think providers, what you think the medical community at large needs to know about working with individuals struggling with opioid addiction?
It's something that primary cares and patients need to communicate very closely about. It shouldn't be something that's swept under the table. I think that patients need to advocate for themselves as well, to look into their family history and see if there's any genetic addictions, and really do your research before you agree to take something that can be so highly addictive and destructive.
So really having an informed consent, you feel is really important.
Absolutely.
Okay. Anything else you wanted to add? Or?
No.
No? Okay, well, thank you so much. You did a beautiful job, as I knew you would, sharing with us, and I'm sure there'll be some questions for you in the Q&A. But I'm just going to go through a couple more slides to just highlight some of the things that Deanna brought out in her story. Here's a list of common risk factors for those that are more likely to develop opioid use disorders between the ages of 16 and 45, people that have had prior or current substance use issues, a significant psychiatric history, history of physical sexual abuse or trauma, and family history of substance use disorder. Those are important things to inquire about before starting individuals on opioids. There's several other tools that can be utilized to help prevent these opioid use disorders from developing. Risk assessment stratification tools, consulting the prescription monitoring program to check for evidence of early refills or doctor shopping, utilizing treatment contracts, which should include a thorough informed consent, including a discussion of the risk of addiction, discussing proper medication disposal with patients. I've definitely seen some of my patients have first gotten introduced to opioids by finding an old prescription in their mother's medicine cabinet. Minimizing concurrent use of benzodiazepines or other sedating meds, particularly to help mitigate the risk of overdose deaths. And a real tangible and practical thing that can be done is to shift from writing 30 days prescriptions of controlled substances to 28-day prescriptions, so that it's predictable when a given patient will run out on the same day of the week in any given month. It eliminates running out on the weekend and then going like Deanna had that was how she first ended up in withdrawal, and maybe would have been tempted to turn to the streets or something like that. And it can help for confusion around on-call coverage and things like that. So that's one strategy that can be used. In terms of identifying behaviors of those who may be addicted, which we call aberrant behaviors, some things you can look at are behavior in and between office visits, physical exam findings such as track marks or evidence of intranasal use, random pill counts and urine drug screens. There are screening tools out there to help with identification of aberrant behaviors, and one's included in the resources handout. And establishing relationships with pharmacists, I think, is also important, who kind of see the patient in a different way as they come in for their medications, can fill you in if a patient is buying hypodermic needles, for example, which can offer valuable clues. In terms of specific aberrant behaviors that are good to keep an eye out for, I kind of categorize these into red light and yellow light behaviors. So more kind of red light, there's probably something going on here. If there's evidence of intranasal or IV use or doctor shopping, repeated lost or stolen prescriptions, repeated requests for early refills, patients appearing sedated in the waiting room or in office visits, reports from others that maybe patients are selling or stealing medications aren't always reliable but often do indicate something might be going on, and urine tox results that either show no evidence of the substance that's prescribed or evidence that other substances of abuse are present. Some behaviors that might indicate some issue, patients requesting specific medications, for example, more potent opioids, requests for dose increases, an isolated instance of a lost or stolen prescription or early refill, reluctance of patients in signing releases of information to discuss with other providers or therapists, any concerns, if you see any increased emotional dysregulation in the office, or a poor response or reluctance to considering alternative interventions to opioids, I would also raise some suspicion. And just in closing, a word about treatment. Deanna really nicely described the multifaceted treatment that she's made use of in her recovery, and I think it shows treatment is really a three-legged stool with psychosocial interventions such as intensive outpatient programs, individual therapy, and residential, which is necessary for some individuals. Also, the self-help, AA, SMART recovery, 12-step groups. And the third leg of that stool is medication treatment with buprenorphine or Suboxone, which Deanna is prescribed, methadone or naltrexone, also known as Vivitrol, which is a valid option for some patients as well. So here's some resources, and this is, there's a copy of this in the handout section for you to click on. I would highly recommend that first link, the pcsso.org website, the Physicians Support System for Opioid Prescribing. It has so many good resources on there about this problem and lots of valuable tools and links to check out. And here's some other other ones that might be of interest too: sample treatment contracts, screening tools, treatment resources, and more about safe medication disposal. So thank you. Now I'm going to turn it over. There's my references for your information. I'm going to turn it over to Terry for the second half of the presentation.
Thank you, Leah, and thanks to the Maine Health Management Coalition for inviting us here to talk about opioid use disorders. I'm Terry Leisure, and I'm an employee of Midcoast Parkview Health Services. I'm a coordinator for the Addiction Resource Center and also co-coordinate our employee assistance program. I've been working with people who have substance use disorders since the mid-1990s. Today we're just going to continue talking about opioid addiction, and my focus is going to be the impact of opioid addiction in the workplace. I'm hoping to highlight the prevalence of opioid use and abuse among people who are employed and how the use of opioids can quickly become problematic. I also plan to review impairment warning signs and steps that can be taken by employers to help their employees address substance use issues. I think one of my greatest hopes is to help employers become more comfortable talking with their employees if they have concerns, and identify some specific steps that can be taken to help employees get into treatment. Substance abuse in the workplace is a serious issue. Employees experiencing substance use disorders isn't a new problem. In 2011, the Department of Health and Human Services classified 18.9 million adults with substance dependence or abuse, and nearly 52% of those adults are employed. And when we talk about substance abuse, it includes the abuse of alcohol, drugs, and, as we're talking about today, prescribed medications. Back in the 90s, when I first started doing this work, we were having this discussion. Our focus would be typically on employees with alcohol use disorders. But according to a recent study published in the Oxford Journals in 2011, prescription opioid abuse alone cost employers $25 billion in 2007. Opioid use disorders, actually alcohol use disorders, tend to have a slower progression than the progression of opioid use disorders. And what that really means for people is that their lives fall apart at a much faster rate, and they are at significant risk for overdose. Today, the rate of opioid or opiate overdosing is increasing. Overdose is typically tied to the use of an opioid or an opiate alone or in combination with other drugs or alcohol. An alarming statistic is the sale of prescribed painkillers and fatal poisonings quadrupled from 1999 to 2010. And I think that we really know that those rates have increased since 2010. From a recent historical perspective, medical providers back in the 90s were charged with the responsibility of decreasing chronic pain, which led to the increase in the amount of opioids prescribed and will often lead to opioid addiction. The state of Maine addressed this issue through the Maine Care system, attempting to limit long-term opiate prescriptions with the implementation of a pain management policy. And I think that some of this has contributed to limited access to the synthetic opioids, increasing the price of those drugs for sale on an illicit basis. Many people turn to heroin because it's easier and much more affordable. I think some of the IV intravenous heroin users of today are people that started opiate use with prescription opioids. Opioids continue to be prescribed, which is really challenging for employers because employees have a legal prescription by a licensed provider for the pain. Opioids are powerful, highly addictive drugs that have the potential to cause impairment, workplace accidents, errors and injury, even when it's taken as prescribed. Employees who are prescribed these medications often have trouble making it to work because they're preoccupied with finding drugs to avoid withdrawal, or they're in active withdrawal and can't imagine going into work. They often lose their jobs, but sometimes they're able to hide their abuse of prescription drugs. If they're not absent, the issue really becomes what we call presenteeism, and meaning that they come to work even if they're sick, which results in decreased productivity. This is a slide that shows the different parts of the brain that are affected by addiction, and I think that the key issue here is identifying the difference between dependence and addiction. If someone becomes dependent on opioids, their body relies on the drug to feel normal. But using opioids to avoid withdrawal is not addiction in itself. Physical dependence all by itself is predictable and can be easily managed with medication and is ultimately resolved by a slower taper off the medication, as Deanna had described the process that she tried to engage in to get off opiates. Addiction, on the other hand, is uncontrolled cravings for the drug, inability to control use, compulsive use, in spite of that creating harm to self or others. However, even if employees aren't addicted, they can still show signs of impairment due to the use of the drug. Some of the impairment warning signs, I think it's really important to note that you want to see multiple symptoms present. If they don't, if you can see any of these impairment warning signs in any of us, probably one at a time, and it doesn't mean that we're impaired. But if you take a look at the whole picture of somebody, you'll see poor mood. A real hallmark mood issue is irritability with the use of opioids. Often people feel depressed and anxious. Their productivity is decreased, not functioning well. Their performance is poor. They're distracted, clearly focused on something else, maybe getting a lot of different phone calls, personal phone calls while they're at work. They are late for work, or they're absent because they know they're going to be in withdrawal and not able to work. You can see physical changes, loss of interest in personal care, maybe bloodshot eyes or pinned pupils, weight gain or loss of coordination, speech, withdrawal symptoms that look like intense flu-like symptoms, and I think that Deanna did a really good job talking about that, and oftentimes financial trouble. All right, so some steps that can be taken, and these are steps really looking at kind of a policy level from the employer perspective, and it can help supervisors and the employer to be able to express concern or feedback to an employee and decrease the level of discomfort. It's a really difficult thing, I think, for supervisors and employers to address a substance use issue. They don't want to be responsible for an employee losing their job. So we'd want to consider a workplace drug testing policy. A lot of companies already have in place pre-employment drug testing, but that doesn't really address situations where employees are prescribed opioids after being hired. On-the-job random drug testing is less common, except in workplaces where the work is safety sensitive, such as DOT jobs. People are operating machinery that could harm themselves or other people. Drug testing doesn't prove that the person is impaired. It just means that at some point they have used that substance. Proving an objective measure of unsafe impairment is really quite difficult. Safety is the key and really should be the emphasis. Let's see. So again, at a policy level, employers should consider a written policy that prohibits the use of drugs or alcohol during work hours and also details employer action if an employee's performance is being affected by use after hours. The policy should include the process for notifying the employer if the employee is prescribed a medication that could impair their work performance. So employees being very aware that that is something that would be expected, that if they're prescribed a medication that could impair their work performance, that they hopefully are contacting their employer about that. So some steps to be taken in terms of addressing a specific employee if you're concerned about their use of substances. Take some time to gather your resources. Many companies have an employee assistance program that's designed to assess and refer their employees to treatment. If you don't have an employee assistance program, you can gather information about community resources, who are the treatment providers in the community, and it's often advisable, and in most cases, the people that have been referred to me through our EAP, our human resource rep has been very involved in that process. You're going to want to explore employer insurance coverage for treatment of substance abuse problems, because insurance coverage varies widely. And then you're going to take action. And this is really, this can be the difficult part, having a private conversation with that employee. You want to observe and document your specific concerns, and review the company policy, provide the employee with resources. You really need to let the employee know if their job is on the line, and document that. And often that process can be achieved with human resources. It's important not to be vague. You want to identify specific and performance issues, such as attendance, missing deadlines, different types of behavior on the job. And then, of course, you want to consult an attorney to be sure you're complying with all state and federal laws. So what is EAP? EAP, Employee Assistance Programs, are confidential. We tend to work with employees on a very short-term basis, 1 to 3 sessions, and then refer to treatment. Our Employee Assistance Program and most others are offered as an employee benefit. Even if employees don't opt for your health insurance coverage, typically they can still access EAP benefits. Our EAP offers assistance to managers and supervisors to help them work through the problem, help them to identify what to document, how to address the issue. Again, it's really in the best interest of everybody. It's a win-win situation to identify an employee's substance use disorder. They're often grateful, and by the time their behavior gets to the point where they're being referred on to treatment, they're really aware that they have a problem and want to participate. Employer-sponsored treatment is cost-effective. It is much cheaper to retain experienced, qualified employees than to lose a valuable employee and have to rehire and retrain. 70% of all U.S. companies and 90% of Fortune 500 companies purchase EAPs because it does improve the bottom line. Sadly, though, only 3 to 4% of employees actually access EAPs because they're really concerned that whatever they share with an EAP provider will get back to their employer. They often aren't aware that it isn't going to cost them any money, and they're afraid of repercussions. Included in this website and webinar, I've added a handout, which is a question and answer handout that we provide to our employees that addresses some of their concerns around confidentiality and really explains what an EAP is and how it can help. I have a link attached, but I'm not sure that that link is actually working, so that's why I've attached the handout. So I guess at this point, are we open for questions?
Yes, thank you so much, Terry and Leah and Deanna. Thank you very much for all the information. It's greatly appreciated. At this time, if you have yet to put a question in the chat box and would like to, please do so now. But I will start with the questions that we do have. Deanna, would you mind letting those in attendance know what you perceive as your plan for how long you'll continue to take Suboxone?
Yes, my initial plan was to be on it for a year. I've had some personal struggles with some family death and a breakup that has made my recovery a little challenging, and I thought that it would be in the best interest to continue to stay on Suboxone until I'm positive that my life is on track.
Okay. Sounds like you've made some sound judgments there. Thank you. Terry, what is your suggestion for employers who do not have an EAP because they're too small?
So I guess that I would hope maybe that they have a huge resource department, and maybe not if they're that small, but they can, you know, depending on where they are, you can search the web for resources for treatment. You could give us a call, and we can walk through at the Addiction Resource Center, and we can walk employers through the process of having that discussion with their employee and making a referral for treatment. Okay.
Some good suggestions. Thank you.
The other piece, Marie, is that actually employee assistance programs are very inexpensive to purchase. They usually are about $20 to $40 per employee per year.
Oh, wow, that is surprisingly affordable. Good to know. Leah, can you answer if a provider feels like their patient is hiding some addiction issues from them or has been lying to them, do you have suggestions about how to deal with that?
That's a really good question. I think that's a tough one that a lot of providers struggle with. And how to make a person feel like you're not shaming them or being very suspicious of them and creating this more adversarial dynamic is what the hope is, to avoid them. And I guess any way to kind of normalize that and de-shame that would be really helpful. Maybe saying something like, you know, I've been doing this a long time, and I've seen a lot of people struggle with addiction. You know, that have shown kind of similar patterns to you have, and I'm wondering, you know, it's really okay to talk about that with me. You know, there are resources to help. I'm not going to be mad at you. You know, let me help you if this is really what's going on. Might be kind of a good approach to take. One thing I say to myself a lot, and often to patients too, is like if someone that's actively struggling with addiction, like I trust you, but I can't trust your addiction, and really trying to separate a person and their own values and morals and who they are, all their good things, away from this kind of part of them that's really their brain hijacked by this brain disease, is a way, I think, for me to approach patients with a more consistently compassionate stance. Dan, do you have anything to add about that? You can totally say no about like how doctors can approach patients that they might be concerned about.
Most definitely being empathetic and showing compassion, and not for punishing them for something that they really don't have control over. I think that would be a great approach from what you said, that I trust you, but I don't trust your addiction, because most of the time we're just good people that have made bad choices.
Yeah.
Interesting. Okay. I have two sort of related questions about covering the cost for treatment. One is directed to Deanna, which is, did you have main care coverage to pay for your treatment? And if not, how did you pay for your treatment? And then for our presenters, are there grant funds available to assist those who do not have insurance coverage at Mid-Coast Addiction Recovery?
Yes, I was awarded disability in 2009. So I have Medicare and main care as insurance. So my copays were zero. I haven't paid very much out of pocket for my treatment.
From the provider perspective, the Office of Substance Abuse here in the state of Maine funds several treatment programs throughout the state. We are one of those treatment programs. We are able to provide the psychosocial treatment portion at a very reduced rate, typically $5 to $10 per session for clients, and then we also are able to help them out with between 30 and 50% of the medication costs.
Okay.
Suboxone.
I'm sorry?
For medication costs for the Suboxone, if that's the route the client wants to take.
Oh, I see. Okay. There's another question for Terry in regard to giving the supervisor at a place of employment the correct tools when training alone doesn't seem to make a difference. What might you suggest in that instance?
That's a really good question. I would encourage an open door policy. It sounds like training has been attempted. For sure, we want our management staff to be aware of what the signs are and what to do. But I think that having that open door policy with EAP providers so that they feel comfortable reaching out to an EAP provider and having a conversation. They don't have to use the employee's name, but brainstorming how to address the issue. I think making it really safe to do that, and I think it's really more of a shift in perspective that we're not punishing the employee by helping them get into treatment, but we're really helping them.
Okay, we are at time, but I will squeeze in one more question, and those who need to drop off, can do so, just because we have so much interest. So this last question has to do with the success of treatment contracts with providers, between the provider and the patient, and what are the repercussions, or how is it handled if the patient breaks that contract?
I can only speak for the contracts we have with patients, which is around medication with Suboxone, which is a highly controlled substance. So we have some pretty specific contracts that we ask people to sign around how to appropriately use that. And it's a great thing to fall back on, to refer to help turn what can easily turn into an argument between a provider and a patient around, how are you using this medication. To refer both parties back to the contract can be helpful. But with that said, we don't, here at the Addiction Resource Center, at least, it isn't, we don't really take it as gospel always. There are certainly individual circumstances that are numerous that come up for people to deviate from the prescribed contract that they've signed. And so we take individual circumstances into account and really look at how the person's doing overall in their recovery, how they're demonstrating that they're improving and that they're engaged in a comprehensive recovery program, and then fall back on the contract as needed to kind of enforce the boundaries that we do need to keep to ethically prescribe the medication.
Okay, thank you. So that makes sense. Well, we're very grateful for the time and expertise and personal stories that the three of you have contributed toward, and also for our attendees who've tuned in today. I would like to remind our attendees to please take the survey at the conclusion of this webcast that will pop up on your screen. And if you have interest or questions about the Maine Health Management Coalition or are interested in membership, please contact me. My phone number is at the bottom of the screen, as well as my email address. So thank you so much to everyone, and enjoy your afternoon.
Thank you.
Thank you.